This is a different presentation, a little bit more geared to lower extremity. Not everything that I say is really pleasant. I even thought I should put a more serious tie on so it would reflect this presentation. It's a little bit of a wake-up call for all of us because I think over the years a lot of things have happened to lymphedema therapy that is not necessarily in the best interest for the patients. And so please don't throw any rotten eggs or tomatoes at me. I'm just kind of like sharing my opinion here, and I'm going to get back why I called it Back to the Future. A little quiz for the ones who are not here. I know we are a little bit under time pressure because I'm supposed to finish at 4. What is this? Anyone? Any wild guess?
The amount of patients who filed with insurance for lymphedema.
Say again?
The amount of patients that filed with insurance for lymphedema.
The amount of patients that filed insurance. No, not that. What else? One more guess? No. This is the attention curve of a 40-minute lecture. This is research, this is science. I didn't make this up, I didn't draw it up. So we are right now in my lecture, I'm about here, so we still have good hope for a little bit of a peak. This is where you pull your cell phone out, check your messages. And this is about when I say in conclusion, okay? So just a little fun fact, I mean, we all have an attention span that is only so long. And I want to comment or compliment you for being here and with your eyes still open, ears still open, listening to me here for the second lecture. So kudos to you for your stamina and for your perseverance. And I do invite questions. I rather save a few of my slides. But I invite questions if you have them, and we'll try to be a little expedient here for the last lecture. Of course, we treat lymphedema. I hope some of you were here this morning, so you kind of like it hooks into the presentation. I don't want to be redundant with what I already said. This morning, we treat primary lymphedema, we treat secondary lymphedema. This time, it's a little bit more geared to the lower extremity. And we treat obesity-associated lymphedema, and I think that's what we all need to learn. Where is the differentiation? Is it primary? Is it secondary? Is it maybe a multifactorial lymphedema? And nowadays, we get more and more patients with more severe lower extremity lymphedema, and these folks need help. But we need to also address what brought the lymphedema on in the first place, right? And I'm not a weight loss person, I'm not a nutritionist, but I do have a couple recommendations to make along the way. But these are real folks, and they were all treated, and I show you in each case the before and after pictures, even though these two folks were not my patients. That's from Donald Thomas, and that's from Linda Rorty. This morning, I kind of like started off saying the good news. The good news is that secondary breast cancer-related lymphedema has definitely, the number of patients who develop lymphedema after breast cancer surgery has declined, and that's a great news, right? And the ones that we are seeing now, they're not as severe as they used to be. The not so good news is that we have an exponential increase in patients with here multi-causal. We sometimes call it multifactorial. That means the same thing. It means that there's different things responsible for them having developed lymphedema. And some of them are internal issues, some of them lymphatic issues. One may turn into the other. And then you have this mixed bag of things that cause lymphedema in the lower extremity. I want to share some general considerations on that. And the first recommendation to the clinicians in the room. Can I get a quick hands up? Who is a clinician, a lymphedema therapist? Is it still half-half? Thank you. And then we have patients in the room and their spouses. Okay. and that's the other half. So it's about half-half. And what I find in my travels, because I do this for a long time, I go places, I speak to patients. I met this patient last year, and the assumption is that this patient will come into a CLT, a certified lymphedema therapist, with a strict, lymphedema evaluate and treat. Okay, and then the therapist rolls up their sleeves and they go to work. The question here is, was that patient a primary lymphedema patient? Was it someone with lipedema? Maybe a mixture of the two. In the differential diagnosis, we have to worry about cardiac status. It means, is their heart okay for us to treat them? Is the kidney liver status good enough, or is there maybe a little bit of renal edema or hypoproteinemia that contributes to the swelling? All these things need to be checked. Diabetes is likely in patients that we treat, venous insufficiency. When you have lower extremity lymphedema, the breast surgeon this morning already mentioned it, every third person, or whatever the statistic was, has venous reflux. That means there is a vein component that contributes to the lymphedema. So it's not a pure lymphedema anymore. And then the obesity, I put this here on top, but brought it in as my last click, or actually second to last click, because I get a lot of reports from all over the place about advice in the treatment of lymphedema, and I would read all of this, and then the obesity is likely to be mentioned on the bottom where it should be mentioned on the top. I'm serious about it. I don't think obesity is anyone's fault because it's a complex disease, and I try to highlight that in my next slide. But we should mention it on top. This is not primary lymphedema. This is not lipedema. This is obesity-induced lymphedema. I'm not a physician, that's my little disclaimer, but I have done it long enough to take a stance and say, we need to be honest with our patients, because this is what's happening in the medical world. We are putting our blindfolds on, and we don't address the obesity component because it's complex. It's not an easy fix. If we had an easy fix, we all wouldn't be. I'm overweight by BMI, I'm obese, okay? And we wouldn't be if it was an easy fix. But addressing the obesity is one of the critical factors in having long-term success, because I've done it, I think I mentioned it 5 times already, long enough to see people going through treatment, through the cumbersome wrapping, the agony of like going to another appointment and being wrapped and being more immobile than what they were before they came, right? Because now you're adding a few layers of compression wrapping, and it makes them, it's cumbersome, it's difficult, and then they don't enjoy the long-term success. It has to be, there has to be a different way. Obesity, I put this slide in because I'm not a nutritionist. I'm not giving you nutritional advice. But I put this in to realize for all of us that obesity is a complex disease. It's no one's fault. It is genetic and epigenetic. If you have not ever heard about epigenetics, do look it up. It's such an interesting field. It's basically, you're born with your genetic makeup, but then as a breast surgeon alluded to, over a lifetime, things change based on what you are exposed to. And that starts in the womb. That starts before you actually are born. Epigenetics is a very, very important and very interesting field. But it's also our environment, what we are exposed to, right? It is our mental health, stress. Has anyone ever eaten because they were either depressed or they were stressed? Definitely me. Okay? And sugar. Sugar is the main culprit because it does cause chemical changes in the brain that are oftentimes compared to the changes that you get from drug use, right? Cocaine use, for example. So it is a complex thing. It's not just one thing. And solving all of this at once, there is no magic one, so I liked your clicking the heels, right, Dorothy? If we could do that, we would. For the therapist, be a little cautious, suspicious when you take in a patient who seems to have obesity-induced lymphedema, because we want to check, is it a bilateral swelling? Is it symmetrical? Right? Sure, it could be lymphedema, but it could also be heart disease. It could be that that person is short of breath walking into your clinic. We need to recognize that. Sudden weight gain, it is not normal. Even for someone like me who really likes to eat, it is not normal to gain, let's say, 30 pounds in 2 weeks. We can't eat enough to do that, okay? High blood pressure, or BMI, diabetes, hypertension, that's the HDI, it's high blood pressure, can all cause a multitude of issues that contributes to the edema. So treating someone with obesity is a complex project. Unusual blood volumes, there's blood volumes that can point to heart disease, kidney failure, but be aware, blood work is like a COVID test. It's only true for that particular moment. It's a snapshot in time, right? I can do a COVID test today, be negative, and be positive tomorrow. I can have great blood work today, and in 5 weeks, that blood work would show exactly different. This is an important slide because I want to share some other additional considerations for the clinicians in the room. This is an important question, should be on anyone's intake sheet. What is your sleeping position? Okay, if that patient sleeps in a recliner, I know the reasons. It's hard to get in and out of bed. They're short of breath, right? And they need to be upright a little bit. But that person, in my opinion, needs a hospital bed more than a lymphedema therapist. Don't put the cart before the horse, because I have been over and over consulted on cases where, oh, the lymphedema treatment worked so well for the first 2 weeks, but now I'm stuck. And after talking to therapists on the phone for a long time, I would sometimes after 20 minutes or 30 minutes even say, you know what, let me guess, your patient is such and such weight and sleeps in a recliner. How did you know that? Because it's a recurring theme. And I would recommend any lymphedema therapist to ask that question. What is your sleeping position, right? We need to look at the general condition of the patient. We need to pick up patients where they are, and you are good at it. We are good at tuning in, but we don't have to compromise the quality of our lymphedema care. I cannot make this person run a marathon tomorrow, right? She would never do it, I would never be able to do it. So we have to pick them up where they are. We need to look at nutritional status, because just because you're large, that doesn't mean that you eat too much or that you are eating healthy, right? Patient support system. I would oftentimes say, look, establish the framework first for success before you roll up your sleeve and go to work. Just like Missy was saying, at the first appointment, I'm already envisioning, where is this patient going? Where do I, what kind of like product am I using, right? And in regard to products, when you were talking, I mean, what came to mind is the phrase, like, there's a paradox of choice. That means we have too many choices already, right? That's a good phrase of like putting the multitude of products that we have, but we cannot throw all of this on a patient and say, okay, use this and use this and use that, if that person is not ready, or we haven't established the framework for long-term outcomes and success. And then motivational interviewing. We cannot do it. I would oftentimes say to the patient, I'm not the captain of the ship. You are the captain of the ship, right? I'm helping you to navigate your lymphedema, but how far we go depends not on me and my ambition or my skills. It depends on how far you are willing to go with me. right? Because you guys are the captain of the ship. Now, my body weight, I don't even want to call recommendation because I'm not qualified to make that recommendation, but over the years I've kind of like gathered some information, and because it's going to be online at one point, I'm going to say, this is my opinion, okay? This is my opinion. It's not medical advice. It's not a recommendation. But let's look at a couple of things that, you know, would help us to navigate the obesity. Bariatric surgery is an option. Is it an option for everybody? No. It's not a quick fix. It's not easy. It takes a village to go through that successfully, because success is not defined in how do you look 3 months after the surgery. I want to see how are you going to look 3 years after the surgery. And medically, you have to be stable to have this surgery done. The ketogenic way of eating gets a lot of publicity, and you know, I think we need to rephrase it a little bit. I was even thinking of taking the word keto out of this, but it's so faint you can hardly see it. Anyway, so it's more like a lifestyle than a diet, because diets don't work. The success rate of a diet is very, very low in the long term, right? There is, I'm going to just say this right now because it's eye-opening. If you have a patient who has lost weight through a conventional diet, okay, and I speak to a lot of patients, and I would say, you know, yeah, how long have you been on diets? I've been on diets all my life. What happens? Well, I lose, you know, 10 pounds, and then what? Well, you know, 2 years later I had it back up and maybe 5 on top of that. So what happened then? Well, I went on another diet and I lost 20 pounds. And what happens then? What happens? You know, you lost 20, give it 2 years, and you're back to where you were plus, okay? So the likelihood that you will regain the weight through a conventional diet is 95%. So you're a 5% success rate, right? Would you do that? Would you recommend any treatment that has a 5% success rate to your patients? What I'm saying with that is stop doing it because it's not working. It's not working, so we need to think outside the box a little bit. And I borrowed a few slides from one of our instructors, Leslie Keith. She runs a program with Robert Ekstrom, and they have this lymphatic lifestyle solutions online program. So you don't have to travel anywhere. It does cost a little bit, but it's not an exorbitant amount to sign up for one of those. They have free orientation sessions. I just listened to one of them, and they're very informative. And basically what they do, they look at 7 different criteria of the person's lifestyle. They talk about low carb. I think that's a better way to say it than keto, because it doesn't have to be just meat. That's a carnivore diet anyway. They look at physical activity and exercise, stress resilience, the importance of sleep, you know, life balance, time management, planning for sustained change. That should be highlighted in red and bold. And then, of course, optimal lymphedema management. This is just one of the case examples. They do have a number of case examples. 71-year-old female. She was diagnosed with lymphedema, depression. Symptoms are very common, very familiar to us. Gradual weight gain over time, severe chronic pain, and brain fog. She was ready to go into a wheelchair. Now, this is her a year later, and she lost 46 pounds. And again, you're going like, why is that different from what I just told you, right? You lose some weight, you gain some weight. Well, she really changed not only her diet, but other circumstances and aspects of her life. And long and behold, pain was resolved, lymph volume reduced, energy level improved, her gardening she can now do again, she takes walks on the beach. And you know what's so remarkable is her lab tests are better, right? She's no longer at risk for heart disease, which before she was. So it really improved not only her weight, but overall she improved in many different departments. And I thought long and hard whether I should put those slides in, because these are not my slides and it can feel like a commercial break here. But it's a real tool. It's a real tool for people that need assistance. We are human beings and we sometimes work better with others and with the help of others, right? There's very few of us that can do everything alone, right? And so this is a real option on the way out. On the back table there's some flyers, there's some little business cards with a QR code, and that should be looked into as a real possibility for more like a, I don't know if the word lifestyle change is really the best way to say it, but lifestyle change rather than a diet. Make sense? Are you still with me? Good. And for those who, you know, I talk to a lot of patients and we explore different options. And when a patient comes to me and says, you know, this is my situation and what do we do? Then I'm going like, yes, I'm saying you're the captain of the ship, you guide me how far you want to go, right? And then I would sometimes strike a deal, not that they have to do anything for me, right? But I'm going like, we have a deal here. I'm going to help you with your lymphedema, but you stabilize your weight and be as physically active as possible. That could be very minimal. That could be like going to the mailbox, you know, for a week and back. And then next week you're going to the street corner and back, right? We need to pick up patients where they are. But where our friendship would end, my relationship with that patient would end if I'm doing the work and you're still gaining weight. That's not fair to me. It's not fair to you, because it's going to be very, very short-lived. So I didn't come up with this concept, and it's not my first. I'm using the word recommendation right now, but if things get to a point where you're going like, okay, we need to do something here, and then I'm going like, okay, we'll have a deal. I'll help you with your lymphedema, and you keep an eye on the scale and make sure that while we're treating and the time afterwards, you're not going up. And that can really be a fresh start. It could be a fresh start for someone who has been on diets all their lives because it has not worked, right? It has not worked. The evidence is there. If it worked, we wouldn't have this discussion, right? So stop dieting. Just try to stabilize. Be mindful of your nutrition. Seek the help of the Lymphatic Lifestyle Solutions Program or someone else. You can do a nutritionist, but sometimes nutritionists, I shouldn't say that because you're going to play that, cut that out before you put it on the internet. They are barking up the wrong tree, okay? They do exactly what has failed 20 times before. I do have strong opinions. Did I caution you at the beginning of this? There is no universal agreement of what manual lymphatic drainage is, and I want to connect to the presentation you see, which was wonderful. Thank you for your presentation. But I tell you right now, from an educator's point of view, I have 20 people in every class, but let's say if we have good turnout, we have 20 people in the class. And when I look at, you know, the end of the training, when they all do their little practical exam, the skills of all 20 are different, even though they have heard exactly the same information. They have been with me throughout the training. And so the quality of lymphedema therapy fluctuates or is all over the place. And I want to give you, as a patient, a few pointers of, you know, to look for a good therapist. It's not as easy as looking at the directory, because on the directory you have a person who passes the class. There's many different level of quality at that point, and then it depends, is that person going to come and show up at an event like this and improve their skills or knowledge? And then you have those who say like, oh, you know, I did my certification and now I'm kind of like just doing what I think is the right therapy. And so the quality of lymphedema therapy is all over the place. There's no universal agreement of what MLD is. And the truth is, we need to tune in to the needs of that patient, because there's absolutely no cookie cutter approach when it comes to lymphedema. If you're treating all your patients the same, then you're already kind of like limiting and likely shortchanging some. This is a biggie. A few years ago, this is a true story. A few years ago, maybe 6-7 years ago, way pre-pandemic, someone pulled me aside as I was walking into the classroom, and she goes like, what do you think about MLD over clothing, right? And I'm going like, MLD over clothing, that doesn't exist, right? And I'm sorry if I hope I'm not offending anybody here, but I said MLD over clothing does not exist. Let me talk about this a little bit later. So later in the class, the question came up again, and she said, you know, I said that doesn't exist. People should not do MLD over clothing because you don't even know what the skin integrity is like underneath. You don't know, have they scars? Do they have any other stuff that I shouldn't be manipulating, right? That's number one. But number two, you're also slipping and sliding over the clothes, and you're not providing expert treatment. She goes like, but that's what my colleagues are doing. And at that point, I wasn't completely surprised because I heard it before. Now, it's very common. If you're a patient with lymphedema and you get your MLD over clothing, that is unacceptable. It's unacceptable, and that is the lymphedema therapist I would leave. I know I should have put in my more serious title, because that's a serious thing. And I'm old enough now where I'm going like, okay, I'm just saying it as it is. It's enough. We have, you know, the quality of lymphedema care across the board, of course all the participants here excluded, has suffered over the years, and I'm no longer the enabler for that. I showed you this morning where, you know, and gave you the example of someone just stroking like this. If that is that person's MLD, they haven't learned it from me, and I would not call it such. I ran those pictures this morning, so I'm gonna go and save some time here. You need some stretch, you need some, let me see what the next purpose, at one point I may have a picture where it says, you know, we're looking for spin stretch, we're looking for good contact, and we're looking, Patty, that's for you, we're looking for intent and purpose, right? Because we had that discussion at lunchtime. So intent and purpose are the key words. If you don't have that behind your MLD, I swear you can do it until the cows come home, and you will not see good results. This is from the ALERT program in Australia. They gave me permission to use this. It's a little bit hard to see because it's too light, but this is also indecisive read, just a black and white version of indecisive read. And you see that, you know, that fluid that is now trapped in the tissues is not moving very fast. We don't have to make any judgment of whether this is now an MLD move or just a stroke, what have you. It's not moving very fast. It's moving, but you have to adapt your techniques to the situation. So this person is vastly different from a person who has maybe stage 1 just developed lymphedema over the last 2 weeks, right? This is a person who has more significant lower extremity lymphedema, and the pressure needs to be firmer. Providing effective treatment. This guy, I was involved in his treatment. I'm not taking credits for the results because I'm going to show you his lower extremities in a little bit before and after. I'm not taking credit for the results, but I was involved in setting up the treatment, guiding the therapist through the treatment. And you know, back then when we treated this gentleman, we used a more cookie cutter approach. We did the neck, we did the armpits, we worked on the side here and here. And maybe I would do a little bit of that still, but we changed our approach where the manual lymphatic drainage has to be, you know, when I say proximal, here in the belly area with breathing, we can stimulate our lymphatic system. This is Grand Central Station for your lymphatic system. If you get this activated, and if you have a lift in New York, I don't know, maybe you have a Grand Central Station in Houston too, but we have Grand Central Station in New York, and everything comes together. If Grand Central Station is working, everything is working, right? If this is blocked, everything else will be blocked. We focus our manual treatment proximal and where we do the compression distally. And this is where we change, and we have learned over the years. I tell you right now, some of the lymphedema schools have not changed. They're still teaching a cookie cutter approach like we did 20 years ago. Now we have other tools, the chronic edema, CVI, associated lymphedema, we do exclusively into the groin. And that's what I would do with this gentleman too. This would be my approach. I don't know how well you can see it, but it would be my approach until I feel like I reached a little bit of a plateau. And then I may use some secondary pathways up to the axilla. But we can no longer use time that not wisely. I'm sure there's a better way to say that. That's the way it is right now. We are under productivity pressure, especially when you work in a hospital, so this would be my first setup. We spend a lot of time doing the secondary pathways, and we had success because we did more than we practically had to do. This is his lower extremity in some Velcro-based application. We eventually got him into a stocking, and eventually this gentleman had bariatric, that means weight loss surgery, okay? But I never got a picture. This was at a time when 20 years ago I actually moved from New York, New Jersey to Colorado, and so I kind of like lost touch with this gentleman. Scheduling, this could, you know, easily ruffle some feathers. I sometimes say, okay, I'm not old enough, I have enough friends. So I'm just going to say it as it is. This is a better approach. Sometimes we need more visits, but this is a better approach on the left than the one on the right. Now, what do you think 95% of patients with lymphedema are exposed to in terms of lymphedema treatment? The approach on the right or the left? It's a rhetorical question. It is on the left, on the right, right? On this right. So, when you count the number of circles, each circle stands for a visit, you see more visits on the right than on the left. I promise you, because I do have it in a quote here, I promise you that you actually get more results with fewer treatments if you condense it as opposed to, you know, dragging it out over 10 and 12 and 16 weeks or more. I have seen the most insane schedule where the patient is in treatment for many, many months at a time. And I'm not talking about your patient that I saw yesterday, because there are special patients, they have special needs. This is not a cookie cutter approach, and what I'm saying right now does not apply to every single one of your patients, but it applies to 85% of your patients. If they got a treatment approach like this, they would have better results in a shorter period of time. And the argument that, you know, oh, it requires a lot of co-payments. Well, eventually you have way more co-payments here. Well, transportation is an issue. Figure it out, because they have more trips here than they have there. There's no say no really good argument that you can make against 4 to 5 times a week and get the patient reduced and then into their daytime, nighttime environment. What about my patients cannot come? I just said it, you know, the transportation is the same. They will have more trips in your, shouldn't point to anyone, in somebody's schedule. I save you some trips, okay? So this is not true. I save you co-payments, I save you money, but it's a different schedule, and your hospital administration will not appreciate what you're proposing to them. You need to educate them, because that's another thing. The hospital administration, oftentimes they're not lymphedema trained, right? The supervisors and stuff, they don't understand really what you're doing. You need to have this constant explanation and justification. And luckily, I mean, I was at a committee last year. Is it yes, it was last year. And finally, next month, we will have a publication coming out. I think it's in clinical oncology. I was part of that committee where we actually spell out the recommendation that decongestive therapy, and I'm talking about phase 1, decongestive therapy should be given, because we cannot say must, right? There's no such thing, but should be given 5 times a week in the intensive decongestive phase. So that may give you a little bit of ammunition. It's next month when it should come out in clinical oncology. And these are reputable people. I'm not counting myself into this, but they're reputable people that I worked with, and they have come up with this strong recommendation. Oh, I have to get my patients in because our waiting list is way too long. You know what I say to those people? Lymphedema is not an emergency. If that type of person has an emergency, they're likely not for us. We don't treat cellulitis. We recognize it, we send the patient to the emergency room, and at that point, this is not a good starting point for your CDT. It may happen during CDT, that's unfortunate, but lymphedema in itself is not an emergency. I show you this on, I mixed up my slides, so it wasn't the slide that I was expecting. We have had a young gentleman a few years ago. It was just at the height of pandemic. He moved to Colorado. I channeled him into UC Health, which is our big health network, University of Colorado Health. And he waited. He had severe lymphedema. I show him later. He's in my presentation. Severe lymphedema of both lower extremities. He waited 4 months before he saw a physician, another 4 months before he was channeled into treatment. And guess what? Lymphedema was still there. But I do show you his before and after results. And when he was treated 5 weeks. Now that's more than I'm even asking for. But 5 weeks, and the results do speak for themselves. Why do we need to see the patients? Because the bandaging system that we apply on any patient with lymphedema is a multi-layer compression bandage system. And the bandage, unfortunately, is only as effective as it can be, because if that person truly reduces, which is our hope, right? In 24 hours, 48 hours, that bandage system is ineffective. So we have to do it again, but we cannot let 2 days or 3 days lapse with the patient without bandaging and then start from nearly scratch again. Does that make sense? Did I lose anyone? No? Okay. Well, I know it's that time in the afternoon, but I swear half an hour and we're done. Okay. So we need to really recognize that we have a need to go back to the future. That means we need to go back to what CDT really is. And if it takes a lot of work, because you need to do a lot of education with your administration, with your supervisors and stuff, and I know they all have kind of like all kinds of like obstacles that they see, but it's really important that we bring ourselves back to a system that works better for our patient, because what we are now doing on average is not in the interest of patients with lymphedema. And this is a quote that I got from one of my students here. And she used what we said, what I just described as a pilot project. She says, let me have 5 patients and let me try, this 4 to 5 times a week. I'm always asking for 5 because then if you do 4, it's great. If I ask for 40, we'll do 3, and that starts to become a little bit less acceptable. And she goes like, sorry, the results have been outstanding. Oh, cut that out too. Okay. Layer your garments. Provide night garments. I want to piggyback on that question that Missy got. When is it appropriate to do a night garment? I have a different answer. If the diagnosis includes lymphedema, it's likely that that person will benefit from a night garment. Boom. If you don't have lymphedema, then we can talk about the necessity of a night garment. If your diagnosis includes lymphedema, then it's likely that your patient will benefit from a night garment, and that's an easy way to do it. This is, different types of garments. This is Frankie, not my patient, but I know Frankie quite well. And he was treated by Donald. This was after his first 5 weeks of treatment. Now, I guess in this setting we can say it. Jobst was kind enough to provide the first set of daytime and nighttime garments for free. So thank you, Jeff, and whoever else is in the room here from Jobst, because vendors do that. Vendors do chip in when the patient has financial needs. And Frankie benefited, and he's really carrying through. He was also treated in 2020, so right around the height of the pandemic, everything was more cumbersome, but he was treated eventually he was treated for 8 weeks, but look at his lymphedema. Yeah, that's not overboard. This is him now more recently. Just look at how he's standing instead of like doing this, right? He is now able to walk, and he's very grateful, and he really, he's really doing well. This is another one of Donald's patients before and after, and a layered garment. Layering garments is so important in patients who have mobility issues, dawning issues. You can hardly see it because the transition happens down here. She has bilateral knee highs, and she has thigh highs without a foot. Call them footless thigh highs, call them capri or leggings, but that's what she's wearing, and it looks awesome, okay? So and there are long stories about all of these patients that I can't tell you right now in the time constraints that I have. This patient, who would not say, and this is more a rhetorical question, you don't have to raise your arm, that she has lymphedema. She would easily be I want to say labeled as a patient with lymphedema by many clinicians. We cannot do that. She had no pain. She had no pain, no pressure sensitivity in those tissues. Technically, she does not qualify for that diagnosis. And there's no disproportional fat, right? It's more proportional, so if the upper body is like the lower body, then again, you have one more strike saying this is not lymphedema. I hope I get to those slides with lymphedema because we are using the diagnosis too liberal. She has symmetrical adipose tissue, I give you this. Beautiful garments already made, but she doesn't have a disproportional appearance in her body, and she does not have pain, and therefore she does not have lymphedema. This is her in layered garment. She also has a truncal component to that, which is not shown in this picture. And I will see her next week for new garments. So I'm excited to see how she's doing because she actually underwent bariatric surgery, that is a weight loss surgery. And we'll see how she's doing. I predict that she's moving easier, that things are now going in her favor. This is Stephanie. You saw her in one of my initial pictures, and she benefited from layered garments as well, and then she put some biker short, like true kind of like Spanx on top of that, just to hold everything up. This is Jordan, the young guy. He's early 30s, and this is a guy that waited 8 months for his therapy to start, and guess what? Lymphedema was still there. Vicky treated him. This is him now, I think this year, and this is him in his garments. Okay. No really surgery on his lower leg. He did have 2 LVAs, lymphovenous anastomosis, placed in his thigh, but the lower leg was not touched with surgery. That was all decongestive therapy. The next project is his genital area, which you see is also still heavily involved. Layering garment could be that we put a ferro wrap or a Velcro device on the lower extremity and put a footless pantyhose on top. We already had the ferro wraps from previous treatments, so we saved a little bit of money by not going knee-highs, and we actually did a combination of Velcro and flat knit to be more generic. Oh, this is my break. I'm going to indulge me here. I'm going to do it even if I go 2 minutes over. It's really just a 2-minute video. But if you're able, get out of your chair. You need to get out of your chair. Stand up. Okay. If you're able, and indulge me here for the next 2 minutes. It's probably not even 2 minutes long. I told you this morning I'm not an exerciser, but you do need to move, okay? I got some help. Unfortunately, this gentleman here passed away, but we all remember him. And play with me here.
Bring the leg in, and the arm down, swing to the side.
Yeah, love that little sequence. Are you refreshed? Okay, next 10 minutes, bear with me. I have a little bit of an update on lymphedema, and this is also important because, as a little disclaimer, I'm part of an organization that is called the International Lymphedema Association, and I'm part of a board, and the way this came about is somebody in the Foley Clinic, for some people it's kind of like the mecca of lymphedema therapy. They also treat patients with lymphedema, and there is such thing as lymphedema. But I strongly believe we are too liberal with using the diagnosis lymphedema. By definition here, we should call it a lymphedema syndrome, number 1. In Wales, that's that little sliver of England. I mean, it would probably not be happy because I said it's part of England. They are part of the UK. They don't call it lymphedema anymore. They actually renamed it into the bulger, okay? And you see a real paradigm shift here if you're open to it, because I do strongly believe, and this is where opinions can go, either way, and we can have this discussion. I do believe that we are using the diagnosis a bit too liberal. I, as guilty as the next person, because that's the way I've learned it. Let me just go to the next slide. I've learned this as a definition for lymphedema, but the word lymphedema is already unfortunate, because as I show you later in this short next 10 minutes, there's no edema in lymphedema. It's adipose tissue, and yes, that person can have edema too. They can have lymphedema, they can have heart failure edema, they can have all kinds of edema associated with the adipose tissue, in which case they do have an edema component. But the word lymphedema, the way it is now introduced here or used here, is an unfortunate term because it means fat edema, lip fat edema, swelling. And that's an unfortunate term. Let me go back here. These two documents are really wonderful, I think, because this is the international consensus. This is not my doing. I was not part of the first meeting. I was part of the second meeting. And as a result, there was a brochure. This is about 40 pages, close to 50 pages long. And there's been really a big paradigm shift in how we look at the diagnosis of lymphedema. Now, I do want to acknowledge here that this is not accepted by everybody, right? Some people are very, very strong holding on to old dogma. And, you know, I probably hit that slide, a quote from Albert Einstein, who says, you know, you have to be open to change. You know, it's a sign of intelligence if you're open to change. I'm paraphrasing here because I don't have the slide. But be open in Wales, again, the little sliver of the UK. They brought out this patient brochure and they no longer call it lymphedema. They only put it in parentheses because they want the public to know that this is where you know, the renaming occurs. We are talking essentially about the same thing, but it should never have been called lymphedema in the first place. So this is an example how much you can achieve in a small country, because what Wales is maybe 3.3 million people. That's probably the population of the greater Houston area. I have no idea. But it is 3.3 million people in Wales, and you can accomplish more in smaller countries. I think lymphalgia is a much better descriptor for what we are looking for. And the definition is here. This is from the website of the ILA. It's a disproportionate increase of adipose tissue, which has to be combined with tenderness or pain. And then there's other things listed here, which patients typically very often suffer from. But if you don't have these two things, then it's not lymphedema. We should not call it such, because it will actually take people down the wrong path in terms of their fact-finding and treatment. Now, 4 patients, you already saw the second picture here. They were all diagnosed with lymphedema. Okay, now let's look at each of them and see what they really have. This is the first patient here. She has a disproportionate appearance. Even though we don't see much of her upper body, we can see that the waist is relatively small and the hips are larger in proportion, okay? And her pain was maybe a 4 or a 5 on palpation, that means on the touching of the tissue. She definitely qualified for the lymphedema syndrome diagnosis. This was my patient, the first one was not, but this was a patient that I was involved in. Her pain was off the charts. She would say it's easily a 10, sometimes it was an 11, right? At night I couldn't walk up the stairs because I was so much in pain. Look at her size, it's not huge, okay? It's not huge. She was not a very, very large lady, but you see typical changes that we often actually associated with the lymphedema syndrome, the cuffing here, and then feet are not involved. So she would easily be a lymphedema syndrome patient. Now the other 2 I met along the way, this one here just a few months ago, and she was totally introduced to me as if she had lymphedema. When I asked her, what is your pain level? It was barely over 1, okay? Well, I tell you, sometimes I get up in the morning and I have that too. Okay, I feel like, okay, my legs are not feeling the way they should. This doesn't qualify her for the diagnosis. And this is a real paradigm shift, and people have difficulties differentiating that because they have a hard time stepping away from old dogma. I think she's suffering obesity, And I'm not saying that this is an easy fix. I have also not said that the obesity is her fault, but I'm saying that let's call it what it is and not what we like it to be. This patient here, no pain at all. I'm going to see her next week and I'll ask her the same questions and she will tell me, no, it's not hurting. Does she have edema? Yes, she has edema. If you look carefully, she has edema medial on her knees, she has edema here around her, but that's not lymphedema, that's already lymphedema, and that coincides likely because she is larger and she does not exercise like perhaps we do, right? So there is edema, but this is not lymphedema, this is obesity associated. And when I see her next week, I expect that some of this here is a non-issue anymore. So how do we get from diagnosis of lymphedema to therapy and then to self-management, because that's what it's all about. Diagnosis, the lymphedema organization in Wales has also worked on a 11-page intake form. It's a large intake form, but of course we want to look at the patient's general information, the physical, subjective complaints. I want to know, why is this person coming to me in the first place? What is their observation and objective weight, or we sometimes do a waist to hip ratio, pain, edema, and now the important thing. What is the social and emotional context? This is page 4 of 11. I'm so grateful for that evaluation sheet because you can give it to the patient and they can fill out what they can and the rest you can, help them with. But it actually asks, what is their psychological state of mind? Are they impacted by the way they look? Do they have body image issues? And I tell you, in 80% of the time, that is the case, and that can cause real pain. Physical pain and emotional pain. What is the treatment? Okay, what is the therapy? I think, for the first 20 years of my lymphedema teaching career, I was, doing what everyone else was doing. We would employ CDT, but is that really justified? There is papers out that show ultrasound images. Now, I'm not the one to interpret those images, but you see it in ultrasound, you see it on MRI, that there's really no edema. If there is edema, it is likely from a different cause. And yes, lipedema, obesity, lymphedema, that oftentimes coincide. Yeah, can't talk anymore. But it's not the edema that we need to treat. So traditional CDT is no longer really the standard of care for patients with lipedema. So how important is it to do MLD? And we are almost done. In pure lipedema syndrome, it's not very important. But then people say to me, what about the pain? The pain oftentimes goes away when we do MLD. Yes, but I promise you the pain would also go away if you did some gentle massage, gentle touching. People have received the Nobel Prize for recognizing what massage and gentle touching is actually doing, because it stimulates those seed fibers that would then eventually lower cortisol, adrenaline, and noradrenaline, which lowers stress, reduces pain physically and emotionally. So it's perhaps, I'm the first one to admit it. This is my livelihood. I teach MLD. And I'm saying in patients with lymphedema, you probably don't need to be as specific with your MLD strokes as you think, because any gentle massage would do the same. The people here describe the effects of massage to alleviate pain, inflammation, stress, anxiety. It all makes sense. It helps to improve sleep and improves the tissue situation, which eventually helps that pain. So MLD is okay in the short term. Of course, hey, if this is your business and you want to keep the patient on, is it fair to them? I would use it as a bridge, and that's why that image will come up again, to help establish trust, provide an opportunity for education, not necessarily indicated lifelong. And I want to clarify here, we're talking about patients with pure lymphedema syndrome, not a combination, persons who have a combination of adipose tissue and lymphedema. They should get their MLD. That's a different patient. We're talking about people like this one on the screen. While I was kind of like a little down on MLD right now, the importance of physical activity and compression in patients with lymphedema syndrome cannot be overstated. Walking, swimming. This is a group of therapists who visited the Foley Clinic, and they were bandaged, and we did some Nordic walking. Maybe not very common here in Texas. In Colorado, you see a lot of people with those sticks. And if you go to Germany, you will see people with sticks walking and exercising. It doesn't matter what kind of exercise, just pick the patient up where they are and be physically active as you are. Perhaps not put them on a skateboard. And if you do put them on a skateboard, make sure that they have elbow guards and wrist guards and maybe put a helmet on them. Okay, I know, this is a joke, it's a wonderful picture of someone being active in their compression garments, but maybe not the first exercise you should recommend. What does the compression and activity do? It provides more oxygenation to the tissue. It decreases inflammation. And this is an important picture. And what's so important about those pictures is both women, wear compression, but for completely different reasons. The one with the unilateral, with the one leg compression here, she does it because she has secondary lymphedema, likely from either primary lymphedema, maybe some gynecological histories, cancer, where she doesn't use the compression for edema control, she uses it to benefit the tissue health. Okay, more oxygenation, decreased inflammation, less pain. And here's the slide about the garments for lymphedema. Someone here was asking. And there are a number of garments now very suitable for lymphedema. I see myself, and I put that picture of the bridge there purposefully, I see myself in some ways maybe influential, responsible to build that bridge for people from their diagnosis, from the true diagnosis, to the self-management. And you know, we should all at least think about it, take it as food for thought. And the self-management starts with education. We need to educate our patients, and this is where the patient brochure from the group in Wales, or here that flyer from the ILA, International Lymphedema Association, comes in. We need to educate patients of what lymphedema is, and perhaps more importantly, what it isn't. Understanding the cause of the chronic pain, which can surely be physical, it can also be psychological and emotional. Importance of the physical activity and self-management, wearing a compression, and eventually, you know, replace passive treatments for activities that you learn to love. I mean, there is the activity for everyone out there. You just have to kind of like put your thinking cap on and say, what would I have fun doing, right? And then maybe find ways of little steps. This is a chronic care model pyramid, which means that in a patient with chronic care, the real attempt should be to put the patient in control, put you as a patient with lymphedema in control of the chronic condition. And that's the ultimate goal that we have in patients with lymphedema. I apologize that the writing is not easy to read here, but we need more accurate diagnosis in lymphedema. we should not be as liberal with the diagnosis of lymphedema as we used to be. Receive correct and evidence-based information. Healthy nutrition is equally important as for the persons with lymphedema. And then physical activity and compression. And I really do hope that, if nothing else, it gave you food for thought. Maybe change your perspective on how we look at lymphedema, because my firm belief, and I know I said it 3 times, I'm going to say it a 4th time, we are using that diagnosis too liberal. Okay, and with that, I am 1 minute to spare. Thank you so much.